vascular system mind map, we briefly look at the heart, blood vessels, and blood types. So remember that humans have a closed circulatory system. Let's try and brainstorm all these. Typically, of all vertebrates, there's a closed circulatory system in which the blood is confined to the vessels and is distinct from the interstitial fluid. So the heart pumps blood into large vessels that branch into smaller ones, leading to the organs, and the materials are exchanged by diffusion between the blood and interstitial fluid and bathing the cells. So there are three major elements when it comes to the cardiovascular system: the heart, blood vessels, and the blood. With the heart, the cardiac, can think of the cardiac muscles, highly interconnected cells, and four chambers: the right atrium, the right ventricle, the left atrium, and the left ventricle. Alright, so quick anatomy. Can think of the various valves there: atrioventricular valves, the semilunar valves, the posterior vena cava, superior, inferior vena cava, um, which is also posterior, and the superior vena cava, which is anterior, the right atrium, right ventricle, left atrium, left ventricle, the pulmonary artery or the pulmonary trunk, the left atrium, pulmonary veins, semilunar valves, and those and the exit points. You can think of the aorta, the atrioventricular valves, the left ventricle, right ventricles. Right, so the pathway of blood is simple: superior vena cava, inferior vena cava to the right atrium, tricuspid valve, right ventricle, semilunar valve, pulmonary semilunar valve to the lungs, to the pulmonary veins, bicuspid valve, left atrium, aortic semilunar valve, aorta into the bodies and organs or cells. Okay. So the pulmonary circuits and the systemic circuits, realize that the pulmonary circuit, the blood pathway is between the right side of the heart and to the lungs and back to the left side of the heart, and the systemic circuit is the pathway is between the left and right sides of the heart. And the blood vessels, they are network of tubes. So we have the arteries, arterioles, which move away from the heart, and basically you have elastic fibers and circular smooth muscles. And with the capillaries, where gas exchange takes place, there's one Celtic. It serves the respiratory system. So remember, the arteries to arterioles, then to capillaries to venues, to veins and venues. But remember the arteries, elastic fibers, and circular smooth muscles. Capillaries as endothelium fenestrations, and then when it comes to the veins, moves towards the heart. Skeletal muscles contract to force blood back to from the legs upwards, and there's one-way valves, and when they break, varicose veins form. Alright, so that is one thing that you have to realize. So with the artery, I think of the connective tissues, the smooth muscles, the endothelium, the arteries, arterioles, then to the capillary, and from the capillary to the venule, and then back to the vein. And you know um, the blood, there's a plasma portion and the other portions. So the plasma is a liquid portion of the blood that contains the clotting factors, hormones, antibodies, dissolved gases, nutrients, and waste. With the blood, erythrocytes, that's the red blood cells, they carry hemoglobin and oxygen, do not have a nucleus, and live only about 120 days. They do not repair themselves. The leukocytes or the white blood cells fight infection and they form in the bone marrow, and there are several types. There are 5 types: neutrophils, lymphocytes, eosinophils, basophils, and monocytes. With the thrombocytes, platelets, there are cell fragments that form in the bone marrow from the caciocytes, and blood clots by sticking together via protein fibers called fibrin. Okay, so some disorders of the circulatory system, think of anemia where there's lack of iron in the blood, low RBC count, leukemia where there's white blood cells proliferating widely causing anemia, and hemophilia or the bleeders disease, which is due to lack of fibrinogen in thrombocytes, with heart murmurs usually associated with heart conditions where there's a abnormal heartbeat caused by valvular problems, or with the heart attack, the blood vessels around the heart become blocked by plaque, and also think of the other name, myocardial infarction. So with the heart, we've already talked about the various parts and the various sections of it. But remember the other supply to the coronary arteries, right and left coronary arteries, the great cardiac vein, the anterior and ventricular artery, and the blood supply to the blood. It's to the heart itself. But the functions of the heart, it generates pressure. It's um it's like routing blood. So the heart separates pulmonary and systemic circulations, ensuring one-way blood flow. So the heart valves ensure one-way flow, regulating blood supply, changes in contraction rates, and also force match blood delivery to changing metabolic needs. So when it comes to the size, shape, and location of the heart, um, the size it has the size of a closed fist, and the apex is planted rounded point of cone, and the base is flat part at the opposite of end of cone is located in the thoracic cavity in the mediastinum. So you have three layers of um, tissue when it comes to the heart wall: the epicardium, which is the serous membrane of the smooth outer surface of the heart; the myocardium, which is a middle layer composed of cardiac muscles and responsible for heart contraction; and the endocardium, the smooth inner surface of heart chambers. All right, so the um, simple squamous epithelium, smooth connective tissue, and fats are the major layers of the epicardium, the visceral pericardium, and with the myocardium, the endocardium, you have the trabecular carni of the endocardial regions. So with the external anatomy, you have four chambers: the two atria and the two ventricles, the auricles and the major veins, the superior vena cava, the pulmonary veins, and the major arteries, the aorta and the pulmonary trunk. Alright, with the valves, we have the atrioventricular valves, which is the tricuspid and the bicuspid or the mitral valves, and the semilunar valves, which is the aortic semilunar valves, and the pulmonary semilunar valves, preventing blood from flowing back. Alright, so with the functions of the heart valves, it closes tightly to prevent the backflow of blood. So simple blood flow through the heart. Realize the superior and the inferior vena cava. From there to the right atrium, tricuspid valve, right ventricle, to the pulmonary semilunar valves, pulmonary trunk, pulmonary arteries, lung tissue, that's pulmonary circulation, to the pulmonary veins, left atrium, to the bicuspid valve, the left ventricle, the aortic semilunar valves, the aorta, and finally back to the body tissues or the systemic circulation, and back to the superior and inferior vena cava. Right, so systemic circulation, note that it goes to the various tissues, and then there is exchange of oxygen and carbon dioxide. The heart skeleton consists of plates of fibrous connective tissue between the atria and the ventricles, The fibrous rings around the valves are to adjust for support. It serves as electrical insulation between the atria and the ventricles and provides site for muscle attachment to the fibrous connective tissue. Alright, so with the cardiac muscles, there's elongation branching cells containing 1 to 2 centrally located nuclei. They contain actin and myosin myofilaments. There are intercalated discs, specialized cell-to-cell contacts, and desmosomes hold cells together, and gap junctions allow action potentials. Electrically, cardiac muscles behave as a single unit. Alright, so remember there's a sinoatrial node to atrioventricular node, but there's a connection interatrial fibers that connect the right atrium to the left atrium, and from the sinoatrial node to the left atrium. There's a Bachmann bundle that causes a depolarization of both atria. And from the sinoatrial node, these are autorhythmic cells that causes contraction, that causes action potential, depolarization, finally contraction of these hearts muscles. Yeah, so basically from the sinoatrial node to the atrioventricular node, if the sinoatrial node is not working, that's an SA node, there's a heart block. The atrioventricular node will take off the function and cause bradycardia. That's a decrease in the heart rate. And from there to the atrioventricular bundle, the bundle of his. So the bundle of the left and right bundle branches or bundle of his. Then from there to the Purkinje fibers. Alright, so when it comes to electrical properties, there's a resting membrane potential present, and the action potentials, which the rapid depolarization is followed by rapid partial early repolarization, prolonged period of slow repolarization, which is plateau phase, and a rapid final repolarization phase and voltage gated channels. Alright, so with the action potentials with the skeletal and cardiac muscles, you could see that the depolarization phase is thick, the resting membrane potential negative central negative h5, the depolarization phase, repolarization phase, hyperpolarization phase, and back to normal. But when it comes to the cardiac muscle, there's a depolarization phase, early repolarization phase. So early depolarization, that's calcium sodium influx. Early repolarization phase where there is potassium efflux, and then the plateau phase where though there is potassium efflux, there's calcium influx, leading to the plateau phase, and from there is still potassium efflux, leading to the final repolarization phase. Alright, so that is it for this is a summary of the action potentials of skeletal and cardiac muscles. Alright, with the sinoatrial node action potential, that one, remember there's a pre-potential phase, and then from there there's a threshold and the depolarization phase and the repolarization phase, and finally back to the pre-potential phase, which continues on and on and on. So with the refractory period, we have the absolute and relative refractory periods. Where the absolute, the cardiac muscles are completely insensitive to further stimulation. You can see this happens within the depolarization and repolarization phases. Relative refractory periods, the cells exhibit reduced sensitivity to additional stimulation. There's a long relative period which prevents tetanic contractions. With the electrocardiogram, the action potentials through the myocardium during the cardiac cycle produces electrical currents that can be measured. And with the pattern, we have the P wave where we have that is the atrial depolarization, the KORS complex, which is the ventricular depolarization, and also atrial repolarization. But then the ventricular depolarization marks up the atrial repolarization. There's a T wave where that is the ventricular or ventricle repolarization. When it comes to cardiac arrhythmias, tachycardia, bradycardia, sinus arrhythmias, premature atrial contractions, you should be able to remember them. So with tachycardia, the heart rate that in excess of 100 beats per minute, and with bradycardia, the heart rate less than 60 beats per minute, and with sinus arrhythmia, the heart rate varies from 5% during respiratory cycle and up to 20 30% during deep respiration. With premature atrial contractions, the occasional shortened interval is between one contraction and succeeding, and frequently occurring in healthy people. Alright, so the alterations in electrocardiogram, you realize if there is a complete heart block, the P waves and the QRS complexes are not coordinated at all. And with the premature ventricular contractions, there are no P waves preceding the premature ventricular contractions. There's prolonged QRS complexes. With bundle branch block, there is they're all irregular, even with the atrial fibrillation, no clear P waves and rapid QRS complexes. The same for ventricular fibrillation, where there is no P or QRS complex or T waves. So with the cardiac cycle, remember that the heart is two pumps that work together, the left and the right half. A repetitive contraction, which is the systole, and a relaxation, which is the diastole of the heart chambers, constitute the cardiac cycle. So the blood moves through the circulatory system from areas of higher to lower pressure. And the contractions of the heart produce the pressure. So the first one is the systole, the period of isovolumic contractions, and at that point the semilunar valves close, retroventricular valves close, and then the period of ejection, that is the second point, still at the systole phase, where the semilunar valves open and the atrioventricular valves close, and then from there you come to the diastole, period of isovolumic relaxation, where both the semilunar valves close and the atrioventricular valves close. And from there, still on the systole, still on the diastole, there's passive ventricular filling, where the semilunar valves close and the atrioventricular valves open. And then the last stage, where there's active ventricular filling in the diastole phase, where the semilunar valves close and then the atrioventricular valves open. Alright, so the events during the cardiac cycle, remember the periods, the systole and the diastole. So the systole, the two major periods, which is the period of isovolumic contraction and the period of ejection, and also with the diastole, three distinct periods: the period of isovolumic relaxation, passive ventricular filling, and active ventricular filling. Alright, so with this, you should be able to recognize them each when you observe the chart. So remember the remember that when it comes to the heart sounds, the first heart sound, or the lap tap, so the lap sound, it has to do with the atrioventricular valves and the surrounding fluid vibrations as the valves close at the beginning of ventricular systole. But the second heart sound has to do with the DAP, which results from closure of the aortic and pulmonary semilunar valves at the beginning of ventricular systole, which lasts longer. The third heart sound, which is occasionally caused by turbulent flow into the ventricles and is detected near the end of first 1/3 of diastole. With the location of heart valves, note that the pulmonary semilunar valve is up, followed by the aortic semilunar valve, and then the bicuspid, tricuspid, and finally the mitral. But when it comes to the surface anatomy, the pulmonary valve could be listened to at the right second intercostal space parasternal line, and the left second intercostal space parasternal line for the aortic semilunar valve, and the bicuspid in the third, and the fourth you could hear also the tricuspid valve, and in the fifth left intercostal space mid-clavicular line you could hear the mitral valve or the bicuspid valve. Alright, so when it comes to the mean arterial pressure or blood pressure in the aorta, mean arterial pressure is the cardiac output times peripheral resistance, and cardiac output is the amount of blood that's pumped by the heart per minute, and the cardiac output is the stroke volume times the heart rate. Right, so the stroke volume of blood pumped during each heartbeat, compared to that of the heart rate, or the number of times the heart beats per minute, constitutes the cardiac output. So mean arterial pressure, cardiac output times peripheral resistance, which is the same formula for blood pressure, and then the peripheral resistance is the total resistance against blood that must be pumped. The cardiac reserve is the difference between the cardiac output at rest and the maximum cardiac output. Alright, so remember these: the cardiac output, stroke volume times the heart rate. So when the mean arterial pressure is being measured, there are several factors that do influence it. So there is a decreased blood pressure, decreased blood pH, decreased blood carbon dioxide, oxygen levels, exercise and emotions. There's increase in pathetic stimulation, decreased parasympathetic stimulation, increase epinephrine and norepinephrine secretions, and this could lead to increased heart rate. And the increased heart rate will increase cardiac output, which in turn increase the mean arterial pressure. From the increased systemic sympathetic stimulation with decreased parasympathetic stimulation, increasing epinephrine and norepinephrine secretion, it leads to increased force of contraction, which decreases end systolic volume, and this in turn increases stroke volume, which increases cardiac output and thereby increasing the mean arterial pressure. If there is an increase in blood volume and exercise changing from a standing to lying position, there's increased venous return, which increases end diastolic volume and preload, and this in turn increases the force of contraction. That's the Stalling law of the heart. Ejects. There's an increase in diastolic volume, which in turn increase stroke volume, increases cardiac output, and there is an increase in mean arterial pressure. So for the regulation of blood vessels, there's increased vasoconstriction. I think of the renin angiotensin and aldosterone system. There's increased peripheral resistance, which thereby leads to an increase in the arterial pressure. Alright, so with the regulation of the heart, there's intrinsic regulation, extrinsic regulation. Intrinsic regulation, which results from normal functional characteristics, not on neural or hormonal regulation. That's when Starling's law of the heart comes in. And there's extrinsic regulation, which involves the neural and hormonal control. So the parasympathetic stimulation comes in, and the sympathetic stimulation also comes in. With the parasympathetic, it's supplied by the vagus nerve. There's decreased heart rate, acetylcholine secreted. With the sympathetic stimulation, they're supplied by the cardiac nerves. Increased heart rate, force of contraction increases. There's epinephrine, norepinephrine release. And with the heart homeostasis, the effects of blood pressure, receptors monitor the blood pressure, effects of pH, carbon dioxide, oxygen. Chemoreceptors monitor monitoring to being heated over here. The effects of extracellular ion concentration, there's an increase or decrease in extracellular potassium, um, which thereby decreases heart rate. So increase or decrease in extracellular potassium decreases heart rate. And the effects of body temperature, the heart rate increases when the body temperature increases, and heart rate decreases when the body temperature decreases. So the baroreceptor and the receptors and the chemoreceptor reflexes, note that the first stage, sensory nerve fibers, the baroreceptors in the wall of the internal carotid artery, and the carotid body chemoreceptors, the baroreceptors in the aorta through the sensory nerve fibers. Afferent system sends impulses to the relay center, integration center in the brain, specifically the cardioregulatory center, and chemoreceptors in the medulla oblongata. Then from there, with the sympathetic nerves and the parasympathetic nerves, depending on the states of the impulses received, if there is increased pressure or decreased pressure, then that will stimulate which if it's decreased, then sympathetic; if increased, then parasympathetic sets in. So from there it goes to the effectors, and the adrenal medulla. There are also sympathetic fibers to the adrenal gland, which could release epinephrine or norepinephrine back into circulation, and also affecting the heart. That is in the sympathetic pathway too. Alright, so let's quickly try and then understand this pathway very well. So the cardioregulatory center increases the parasympathetic stimulation of the heart and decreases the sympathetic stimulation of the heart and adrenal medulla. Guess what? That is when there's definitely increase in the heart rate, and it has to come back to the normal. So the decreased heart rate and the stroke volume results from the change in the autonomic nervous system stimulation of the heart. And there's decreased heart rate and stroke volume, resulting from the decreased release of epinephrine and norepinephrine from the adrenal medulla. So the blood pressure decreases because of the decreased cardiac output, resulting from the decreased heart rate and stroke volume. And then blood pressure within a normal range, but homeostasis is maintained. Okay, so the blood pressure increases only because of the increased cardiac output, resulting in from the increased heart rate and increased stroke volume. But that is when there is what I explained earlier is when there's a sudden increase in the blood pressure, which is detected by the baroreceptors in the internal carotid arteries in the aorta, which affects the baroreceptor reflex. Alright, so but then when there's a sudden decrease in the blood pressure and is detected by the baroreceptors in the internal carotid arteries and the aorta, which is affected by the baroreceptor reflex, there's the chemoreceptor. The cardioregulatory center decreases the parasympathetic stimulation of the heart and increases the sympathetic stimulation of the heart, the adrenal medulla, and this in turn increases the heart rate and the stroke volume, resulting from the change in the autonomic stimulation of the heart. And there's an increased heart rate and stroke volume, which results from the increased release of the epinephrine and norepinephrine from the adrenal medulla, and this in turn increases the blood pressure because there's an increased cardiac output, resulting from increased heart rate and stroke volume. Alright, I think this is very clear. If still on the chemoreceptor reflex with respect to pH, if there's an increase in pH, often caused by a decrease in blood carbon dioxide, is detected by the chemoreceptors in the medulla oblongata, which affects the chemoreceptor reflex, and this in turn increases the parasympathetic stimulation of the heart and decreases the sympathetic stimulation of the heart and adrenal medulla. And the decreased heart rate and stroke volume results from the change in autonomic stimulation of the heart. And the decreased heart rate and stroke volume results from decreased release of epinephrine and norepinephrine from the adrenal medulla. So the decrease in blood pH caused by the increase in blood carbon dioxide results from decreased blood flow to the lungs, and there is a decreased blood flow which results from the decreased cardiac output caused by decreased heart rate and stroke volume. Right, but if there's a sudden decrease in blood pH, often caused by increase in blood carbon dioxide, and the chemoreceptors in the medulla oblongata, which affects the chemoreceptor reflex, are being stimulated over here, and the cardioregulatory center decreases the parasympathetic stimulation of the heart and increases the sympathetic stimulation of the heart and the adrenal medulla, and this leads to an increased heart rate and stroke volume, which results from the changed autonomic nervous system stimulation of the heart. And there's an increased heart rate and stroke volume, which results from the increased release of epinephrine and norepinephrine from the medulla from the adrenal medulla. And there's an increase in the blood pH caused by the decrease in calcium carbon dioxide in the blood, which results from increased blood flow to the lungs. The increased blood flow to the results from the increased cardiac output caused by increased heart rate and stroke volume. When it comes to the other factors, effects of aging on the heart, there are gradual changes in heart function, minor under resting conditions, and more significant during exercise. The hypertrophy of the left ventricle, maximum heart rate decreases, increased tendency for the valves to function abnormally, and arrhythmias to occur, with increased oxygen consumption required to pump the same amount of blood to the total blood flow at rest is about 5.8 liters per minute, and the total blood flow during strenuous exercise is 17.5 liters per minute. And with at rest, out of the 5 liters, 5.8 liters per minute, you have your brain taking about 750 mils, the heart taking 250 mils, then skeletal muscles 1200 mils, the skin 500 mils, kidney 1.1 liters, the abdomen 1.4 liters, and others 600 mils. But during strenuous exercise, out of the 17.5 liters per minute, 750 goes to the brain, 750 goes to the heart instead of the 250 at rest. But 12.5 liters goes to skeletal muscles, and with the skin 1.9 liters, and then the kidney 600 mils, the abdomen 600 mils, and others 400 mils. Okay, so chest x-ray is very important when it comes to investigations of the heart, and during heart failure you could see it by measuring the cardiothoracic ratio, and it's more than 0.5. There's cardiomegaly, and even in heart failure, the transverse diameter of the heart is larger than the diameter of the hemithorax, and you see for the plain chest x-ray of the heart there is increased cardiothoracic ratio. Complete heart block, you see the decreased heart rate or bradycardia, and then with that you can infer that the sinoatrial node is dysfunctional. Alright, so that's something real about the circulatory system. We'll continue later on with other aspects of the cardiovascular system.